you so much. So I'll be talking on pseudo-exfoliation and small pupil. So coming to some basic theory, poor dilatation is due to the sphincter muscle with atrophy of the pigment epithelium and stroma in case of pseudo-exfoliation. The assessment of pupil size should be done preoperatively in order to adopt appropriate surgical measures. And NSAIDs, as Dr. TTL has already mentioned, it will maintain the maximum achievable pupil dilatation during surgery. So viscomydriasis is one of the tricks. You inject viscoelastic inside the eye and it's going to take care of the pupil, at least 1 or 2 millimeter dilatation. But do not overinflate the antechamber in case of pseudo-exfoliation, as it might cause further damage to the zonules. Use of rings, CTR, hooks has to be done as and when required. Initiation of Capsulorrhexis, sometimes if there is excessive zonular laxity, you can start with a bent 26 gauge needle, make a large Capsulorrhexis of at least 5.5, which simplifies the extraction of nuclear pieces from the capsular bag, or else it might pull the zonules and the bag might, the zonules might get torn at that particular area. So proper corticocapsular cleavage has to be done, making cortical removal easier and safer by reducing traction on the lens zonules. So that's a very important step. So choice of IOL should be 1 piece or 3 piece. But recently in all my pseudo-exfoliation cases, I'm placing a CTR with a 3-piece multi-piece lens in the sulcus. So coming to one of the videos, as you can see, there is a pseudo-exfoliation of moderately dilated pupil. I'm starting with my incision. See, a cohesive viscoelastic is injected next to dispersive, which causes a slight amount of viscomydriasis. And while doing the Capsulorrhexis, you'll be able to understand the degree of zonular laxity. If it is lax, then you might have capsular hooks or rings. Now the hydroprocedure is carried out to free the nucleus and cortex as much as possible from the bag, and gentle rotation. Do not give excessive force at this point of time. It will lead to zonular trauma. The phaco, while doing phaco, you have to be careful about not engaging the pupillary margin in your phaco tip. And normally, the pupillary dilation is usually maintained. As these are not floppy iris, the pupillary dilation is usually maintained till the end of the surgery. See here, you can see the phacoemulsification is getting completed. And the pupil size is almost the same as I started. So cortical aspiration, again, you have to be very careful. Do not pull excessively. If you notice some kind of laxity over here, put a CTR inside and then try to aspirate the cortex. So as not much of zonular laxity was noticed in this particular case, I decided to put a single piece lens in the bag. So this is the next case in which you can see the pupil is not that dilated. It is at almost 3 to 4 millimeter. So, and there's quite a lot of pseudo-exfoliation material in the anterior lens capsule. So I tried viscomydriasis, but it didn't help. The pupil is remaining as it is. So what I decided next is I put a Malugin ring over here. And the ring goes inside and is placed at one go. And you can see the lot of exfoliative materials, and as there is some degree of zonular, like I initiated my rhexis with the help of a 26 gauge bent system, and then I did the rhexis. It included most of the exfoliated materials in the rhexis. Then the hydroprocedure and the nuclear rotation. emulsification is done. And since there was some degree of jonular laxity, I decided to put a CTR. This is an old video, but nowadays in this sort of cases, I always put a multi-piece lens in the sulcus. But here I decided to put a single piece IOL. And then disengage the Malugin ring. Which was then brought out. On to my next case. In this particular case, it was a pseudo-exfoliation case which I had operated. The cataract was taken out, cortical matter was aspirated, a CTR was in place, and now I am putting a multi-piece lens inside and slowly guiding the haptic in the sulcus. So this is my routine practice in pseudo-exfoliation these days. I put a CTR in and then put a multi-piece in the sulcus and go for op. To ensure that the haptic has reached the proper place, just lift up the iris and see the haptic is in the right place or not. Thank you so much.